From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello and welcome to this JAMA Clinical Review podcast. I'm Dr. Mary McDermott, Deputy Editor of JAMA, and I'm here today with Dr. Scott Flanders and Dr. Valerie Vaughn, who are co-authors of a JAMA review on community-acquired pneumonia. Dr. Vaughn is Associate Professor of Medicine and Director of Clinical Research at the University of Utah, and Dr. Flanders is Professor of Medicine at University of Michigan. Welcome, Dr. Flanders and Dr. Vaughn.
Thank you.
Thanks for having us.
So let's get started. I wonder if you could tell us, how is community-acquired pneumonia defined? What is it?
Yeah, so community-acquired pneumonia is basically any pneumonia that occurs in a patient that is not currently hospitalized. And that's actually a change in how things used to be defined. We used to have this characterization of patients who had recently been exposed to healthcare and considered them HCAP or healthcare-associated pneumonia, and that terminology has gone away. So now basically if a patient gets pneumonia and they are not currently hospitalized, so whether they're in the community or whether they are in a nursing home and then come to the hospital, those are considered people with community-acquired pneumonia.
And what are the typical presenting features of community-acquired pneumonia? How does a patient present?
So classically, what we like to see for a diagnosis of pneumonia are when patients have two or more signs and symptoms and correlated radiographic findings. And the signs and symptoms we often look for and see in patients commonly are fever, tachycardia, shortness of breath, cough, and sputum production are the most common of the signs and symptoms we see in patients presenting with a concern for community-acquired pneumonia.
And how do you make a definitive diagnosis?
Yeah, I think the hard thing with pneumonia is that's nearly impossible to do. There is no standard for exactly how you diagnose pneumonia. In fact, if you look for an etiologic agent, you only find the bacteria or virus or fungus that causes the pneumonia in less than half of cases. And so what that means is that you're often treating patients empirically for pneumonia based on what you think they might have as their cause, and you're kind of ruling other things out. Dr. Flanders mentioned a patient with cough and radiographic findings could be someone with pneumonia. Well, that's also the way that heart failure might present. Or, you might have a patient with COPD who has an exacerbation and they come in with worsening cough and tachypnea and shortness of breath. And maybe it's hard to tell some abnormal lung findings on a chest x-ray. That's really hard to distinguish up front. So what often ends up happening is you end up diagnosing or over-diagnosing pneumonia or figuring out that they have pneumonia based on how they respond to therapy.
Well, what about chest x-ray? Isn't that a good way to distinguish between those different possible diagnoses?
Chest x-ray is certainly the initial test we would use on anyone with a suspicion of pneumonia, but we happen to know it is not a 100% sensitive test. Many patients end up being diagnosed with pneumonia that have a normal chest x-ray. And in fact, we do reference some studies that have looked at patients that have found CT abnormalities, chest tomography abnormalities of pneumonia, and only about 40% of those abnormalities were actually seen on that chest radiograph. So it is not uncommon for a patient to have signs and symptoms without an x-ray that conclusively shows pneumonia.
So if you have a patient that you think has pneumonia and their chest x-ray is normal, would you get a CT scan?
I think that's a terrific question. I will say it is not routinely done, but as we've realized how challenging it is to diagnose pneumonia, how important it is to not miss other conditions that may present looking like pneumonia. Dr. Vaughn mentioned heart failure. There's pulmonary embolism is a very important diagnosis not to miss, as well as lung cancers, malignancies. We've increasingly used CT to confirm that diagnosis when that suspicion exists. I think that's probably more common in the hospitalized patient compared to the patient in the ambulatory or outpatient setting, where I believe CT scan would be uncommon.
And what are the most common etiologies of community-acquired pneumonia?
Well, that's changed over time. It used to be that we thought of pneumonia as being a disease that was caused by bacteria. And that today is changing, especially if you think about the pandemic we all just went through. And in fact, many patients who were severely ill from COVID had COVID pneumonia. And so we know that viruses can also cause pneumonia, and in fact, they may be the most common cause of pneumonia. In the EPIC study, which looked at patients hospitalized with pneumonia and tried to identify the etiology, this is the study where fewer than half of patients were found to have an etiology, but the most common one that was found was actually viruses. And that can be things like influenza, that can be COVID, although this study actually took place before COVID. So now that's a new etiology we have to think about. RSV, but also all of the other viruses that can cause upper respiratory infections can also cause pneumonia, so things like rhinovirus. That being said, the most common bacteria and the one that we're often trying to treat when we prescribe antibiotics is strep pneumonia, which remains the most common cause of pneumonia. And then beyond that, if you're thinking about other bacteria you need to treat, it really depends on your patient and the severity of disease. And I think that'll come up as we talk more and more today. And even as Scott was saying, would you get a CT scan? The answer is it depends. It depends on the severity of the disease. It depends on the patient and where you're seeing them. And the same is true when you think about what their most common etiology is. You have to think about how severe is the disease, what exposures have they had, and what are their demographics? Is this an older adult where we know that they're more likely to have bacterial infections and could have things like Legionella? Do they live in certain parts of the United States where you have to think about endemic fungi? There are lots of things that go into that conversation based on the patient. But for your standard patient that comes in, viruses are now probably the most common cause of pneumonia, and strep is your most common bacterial cause.
Given the fact that, as you just said, most community-acquired pneumonia may be caused by viruses, should we be testing all patients suspected of having community-acquired pneumonia for COVID, RSV, and influenza?
That is a great question, and I think one that is currently in flux. What we know from current recommendations right now is that the answer to that is probably, would it change treatment? So, for example, influenza, if the patient presents in a timely manner within the first 5 days of symptom onset, we actually have potentially treatment for influenza. For a patient coming in with pneumonia, if you think they could have COVID, especially if they're hypoxic, we now have treatments for COVID pneumonia. So there are certain viruses where we actually have specific antiviral or related therapy, and so testing for those could change management. So the IDSA actually recommends right now that if those viruses are circulating in the community, so if it's influenza season, if there's COVID in the community, you should test for those because they'll potentially change management. In contrast, we have a whole bunch of other viruses, like rhinovirus that causes the common cold, that we can test for. Those tests tend to be expensive, and it's unclear what you do with that information. So if you have a patient that comes in with a chest x-ray that's positive and hypoxia and signs and symptoms of pneumonia, and they test positive for rhinovirus, there's not a specific treatment for rhinovirus, and it doesn't necessarily change your management. We don't know yet. There's not great evidence about whether those patients should have a change in their antibiotics based on whether they test positive for rhinovirus. So it's a little bit more of a case-by-case scenario for whether you test for those other viruses.
Your manuscript talks about a change in understanding of the pathophysiology of community-acquired pneumonia related to the lung microbiome. Could you comment on that?
Yeah, I think the biggest change that we've seen is historically the lung was thought of as a sterile organ, that when there were bacteria identified, they were pathogenic, and that was not a normal state. As we've begun to learn a lot more about how the lung functions and what the normal state is, it does have a microbiome like many of our organs. And in a healthy individual, there's a homeostasis such that there are occasional organisms that migrate into the lung. There's a routine clearance. There's an environment that's not very conducive to dramatic bacterial overgrowth. When patients develop pneumonia, there's a disruption in one or more of those key variables. So what we've postulated and shown and described in our paper is one of three things is likely happening. There's either increased levels of immigration of organisms that get down into the lung parenchyma, into the alveoli. There's decreased clearance. That can happen because of illness. We see that in older patients, smokers that have decreased clearance, or some other variable that affects that microenvironment within the alveoli that allows for bacterial overgrowth, whether there's edema, whether there are concomitant medications, immune suppression. And so the complex environment that exists in the lung, we're developing a better understanding of that. We don't quite yet understand how exactly each of those plays out, but a disruption in any one of those is likely the precipitant for development of community-acquired pneumonia.
And when should the practitioner consider Mycoplasma and Legionella as a potential cause of community-acquired pneumonia?
So mycoplasma, is something that we think about a lot more with younger patients and ambulatory patients. With Legionella, specifically in settings of outbreak or water exposure. So we had a patient recently who had just had a wonderful vacation spent in a series of spas and hot tubs. That should be like a red flag that this is someone that potentially has Legionella pneumonia. We've also seen it in the setting of outbreaks within hospitals if something gets contaminated, and then you can see that would be more hospital-acquired pneumonia, but still a time to think about Legionella. And then we should always at least be thinking about it when it comes to very severe pneumonia, and in part that's because the treatment for Legionella is a longer, more extended course of azithromycin. And so if you have someone who's severely ill, you want to be able to identify that because that would impact your management. So those are probably the populations I would think about that most in.
Let's talk about therapy. What is your first-line therapy for treating an outpatient with community-acquired pneumonia?
When we think about empiric treatment, we really have to think about, again, where are you seeing the patient? How severe is the disease? What kind of comorbidities does the patient have? So in an outpatient that doesn't have any other comorbidities, you can start with something relatively simple and relatively narrow with few risks of side effects like amoxicillin or doxycycline. If you're starting to think about treating a patient who has comorbidities like chronic lung disease or asplenia, then at that point, moving toward a broader antibiotic like an amoxicillin clavulanate or a cephalosporin plus a macrolide is probably a better choice.
So you mentioned earlier that most community-acquired pneumonia is caused by viruses. Do you always select an antibacterial treatment when you diagnose a patient with community-acquired pneumonia?
I mentioned before that we are only recently starting to learn how important viruses are in the pathogenesis and the etiology of community-acquired pneumonia. And what that means is we don't actually have great evidence supporting what to do with those patients. I think the pandemic actually offered some really interesting insight. When we started in 2020 with patients coming in with COVID pneumonia, having really severe disease, everybody prescribed empiric antibiotics. And then as time went on, we started to realize that in fact, viruses themselves can cause a pretty severe immune response. And you don't need a secondary bacterial infection to have severe disease from a virus. And people started moving away from prescribing empiric antibiotics for COVID-19 unless there was evidence that the patient had a bacterial infection. So they had risk factors or they developed hospital-acquired pneumonia, in which case those patients were more likely to have a concurrent bacterial infection. So what that means right now is that there's really wide variation in practice, and probably whether patients should be getting empiric antibiotics if they're known to have viral pneumonia, again, depends on how severe their pneumonia is. In the outpatient setting, if you have someone that comes in, they test positive for COVID, and they have a cough, but they're otherwise feeling pretty well, you're not going to prescribe antibiotics to that patient. If you have someone coming in septic shock to the ICU, you're going to prescribe empiric antibiotics to that patient. And then the patients in between are a little bit more of a gray area, probably depending on a whole host of factors. This is where biomarkers potentially play a role. If they have a negative procalcitonin, it might make you feel comfortable with not prescribing antibiotics. Whereas if they have more severe disease or underlying comorbidities, you might move in the direction of prescribing empiric antibiotics. So there's no definite right now 100% correct choice that we know of, and there's a lot of variation. And I think the areas in the middle depend a little bit on clinical nuance.
How about the hospitalized patient with community-acquired pneumonia? What therapy would you select first line?
The current recommendation and the current trial data supports that we use a beta-lactam plus a macrolide as the preferred therapy. I think the addition of that macrolide is especially important the sicker the patient is. Again, thinking back to this concept of risk stratification. So patients meeting definitions of severe pneumonia, certainly patients in the intensive care unit, that is absolutely the case. But beta-lactam plus a macrolide is our preferred initial treatment for patients hospitalized with community-acquired pneumonia.
So what drugs are you referring to specifically?
Most commonly, hospitals are using ceftriaxone or a beta-lactam beta-lactamase inhibitor, amoxicillin clavulanate, for example. Ampicillin sulbactam would be the type of drug that we'd be using combined with a macrolide in hospitalized patients.
Such as azithromycin?
Azithromycin is the most commonly used macrolide for hospitalized patients.
Can you comment on how you use procalcitonin when you're diagnosing a patient with community-acquired pneumonia?
Like many of these diagnostic tests, you have to ask yourself, is it going to change your management? And I think that's critical before you send any diagnostic test. I think the best use of that test is, as Dr. Vaughn described, a patient who is felt to have a viral infection. You start antibiotics. I often repeat that procalcitonin another 12 hours after an initial level. And if it continues to be low, I would discontinue antibiotics in that situation. As Dr. Vaughn says, there are no trials that show exactly how we should be practicing in this particular situation. So in a patient who's not severely ill, you could consider withholding antibiotics in that initial hospitalized patient with a low serum procalcitonin and a virus that's identified at the time of admission.
And for our listeners, just remind us how procalcitonin works specifically. Why is it a marker of bacterial infection?
It's basically an inflammatory mediator that is secreted or stimulated by TNF and certain cytokines that are released in the setting of a bacterial infection, but doesn't go up in the setting of some of the interferons and cytokines that are more common with viral infections. Tends not to be affected by steroids, tends not to be elevated by other inflammatory conditions, such as autoimmune disorders. That has been a challenge as you think about some of the other serologic tests we've looked at in the past, like CRP, white blood cell count, many other variables we consider in patients with pneumonia.
How about preventing community-acquired pneumonia? We've talked about vaccines, particularly in someone who's got a history of community-acquired pneumonia.
We talked already today about how strep pneumonia is going down and not the most common cause of pneumonia. Viruses are now. Vaccination probably helps a lot with that. So vaccination for influenza, for COVID, pneumococcal vaccination in patients who qualify for that, I think vaccination is really important. The other thing that I often see missed as an opportunity is smoking cessation. We talked about impaired mucociliary clearance as a risk factor for pneumonia, and that is triggered by smoking, and that can heal if you stop smoking, especially before developing COPD and other advanced lung illnesses. So if you have a patient that you see that develops pneumonia, that's an opportune time to talk to them about how smoking could be contributing to this and offer them smoking cessation therapy. There are other things as well, especially as people get older. We tend to think of oral and dental health as being a big contributor to pneumonia. And so this hasn't been tested in randomized clinical trials, but probably things like improving dentition, good toothbrushing, getting rid of bad teeth, improving swallow for people who have had strokes or other neurological conditions that have them potentially aspirating, doing other things that can reduce the risk of aspiration, sitting up, small meals, not laying down immediately after eating. Those are all things that can probably potentially help as well.
How about the RSV vaccine? Do you recommend that to prevent community-acquired pneumonia?
I don't think there's enough data out about the RSV vaccine yet. We've seen a lot of RSV, and it's probably a good idea to get it, but we don't have a lot of longitudinal long-term data for that yet.
This has really been informative. Is there anything you'd like to add that we haven't gone over?
I guess the only other point I'd like to make, if you look at what a review article like this goes over in community-acquired pneumonia today versus what existed a decade ago, one of the bigger changes has been this concept of stewardship, both with respect to antimicrobials as well as diagnostic testing. And the more we look at being able to treat for shorter durations, avoid excess diagnostic testing, most of the literature has shown that outcomes have not been worse, and in many situations actually are somewhat better. So this concept of less is more, both with respect to duration, spectrum of antimicrobials, aggressiveness of diagnostic testing, has been an important change in how we think about managing pneumonia in 2024 compared to what it looked like even 5 years ago. And so I guess emphasizing to readers and practitioners out there that are thinking about some of these trade-offs, that's a big, important lesson and new finding.
We didn't talk about which patients should get therapy targeting Pseudomonas and which patients should get therapy targeting MRSA or methicillin-resistant Staph aureus. And that's in large part because the answer is most patients shouldn't. The risk factors that have been validated are really, do they have a history of MRSA growing in their respiratory tract? Do they have a history of Pseudomonas growing in their respiratory tract? Or have they been hospitalized with pneumonia and received IV antibiotics within the last 30 days? So that's a much smaller population than we used to treat. And there have been observational studies that have shown harms of prescribing therapy that targets Pseudomonas or MRSA if it's not needed. So most patients, especially those with non-severe pneumonia, don't require that. And even with severe pneumonia, if they don't have specific risk factors for those things, you should be treating them with a beta-lactam plus macrolide. And then you asked about duration as well. The trials have also started changing there. We used to treat pneumonia with 7, 10, 14 days of antibiotics. And what we see now is that those are probably too long for most patients. So patients that kind of quickly improve, which is about half of hospitalized patients and probably all outpatients, 3-day duration is actually sufficient. And if patients take a little bit longer to improve, probably 5 days is good. And then there are only a few rare conditions, things like underlying lung disease, actually growing staph or actually growing Pseudomonas, where patients need at least 7 days of therapy. And what I see for the future actually is that we are probably going to get to a point where the answer to the question, how long should I treat a patient with pneumonia, is customized to that patient. And the answer is based on how quickly do they improve, what organism do they have. I think this is a big opportunity for patient-centered care and thinking about individualizing treatment instead of having a blanket number for people.
So when you treat an outpatient for community-acquired pneumonia, do you give 3 days of antibiotics so you don't actually give a full Z-Pak or azithromycin, for example?
If we go back to what kind of your patient without comorbidities needs, azithromycin isn't included in that. So those patients in particular can get a 3-day duration. There haven't been great studies on duration in outpatients, just like there has been no great study in outpatients, period, about this therapy is better than that therapy. And a lot of those patients probably have viral pneumonia and don't need antibiotics anyway. What we're doing is that we're extrapolating data on duration from inpatients to outpatients. And we're saying, if you're severe enough to be hospitalized, but 3 days is okay, then 3 days is probably okay for those patients that are not severe enough to be hospitalized. I would love to see more work in that space in the future, but we've actually had studies that have looked at a single day of antibiotics in outpatients and found that to be fine. So I think we're probably doing a lot of overtreatment in outpatients, and I look forward to more studies about exactly what the best options are in the future.
Thank you, Dr. Vaughn and Dr. Flanders, for your summary of your JAMA review article on community-acquired pneumonia. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.